Combination therapy, given the disappointing track record of a single agent therapy in the palliative setting, combination of drugs have been extensively evaluated, and in the early 1980s, investigators from the Wayne State, building upon potential synergy between cisplatin and 5-fluorouracil, reported a major response rate of 70% with a complete response rate of 27% using a regimen cisplatin 100 mg per meter square IV and 5-fluorouracil 1000 mg per meter square per day continuous infusion over 96 hours cycled every 3 weeks in patients with the recurrent or disseminated disease. Other investigators confirmed the significant activity of the regimen, albeit with a somewhat lower major and complete response rate of on average like 15% and 16% respectively. So despite an improvement in the response rate associated with the use of combination therapies like cisplatin and 5-fluorouracil, with increased toxicity demonstrating a significantly statistically or clinically significant improvement in survival compared to single agent. So the meta-analysis is reported by Broman and Cronin yielded similar conclusions. And the activity of paclitaxel and docetaxel in head and neck cancer has fostered the development of an evaluation of taxanes and cisplatin combination. Docetaxel with cisplatin is associated with a major response rate of 40 to 53%, with a complete response rate of 6 to 18%, with a weekly schedule of paclitaxel 80 mg per meter square and carboplatin area under curve 2 appeared more efficacious than every 3 weeks dosing of paclitaxel IV and over 3 hours followed by carboplatin AUC 6 in 2 separate phase 2 studies. And there is a great interest in combination of standard chemotherapy with EGFR directed therapy, and the ECOG study compared cisplatin versus cisplatin and cetuximab as the first line treatment in the 123 patient, and the arm including cetuximab had a significantly higher response rate but no significant difference in the primary endpoint of progression-free survival or overall survival. In the large extreme trial, patients were randomized to cisplatin or carboplatin and 5-fluorouracil with or without cetuximab for 6 cycles. Both median progression-free survival and overall survival were significantly improved in the triplet arm, and the cost of more toxicity, quality of life outcomes were reported to not be significantly different between the treatment arms. Of interest, the data from Vermoken and colleague suggests that the therapeutic effect of cetuximab when combined with the chemotherapy is mainly additive rather than synergistic, and a similar but not identically designed randomized trial evaluated cisplatin and 5-fluorouracil with or without EGFR antibody panitumumab in 657 patients, and response rate and median progression-free survival were significantly improved with the incorporation of the panitumumab, but not the primary endpoint of overall survival. Thus, prior to the development of immunotherapy, the standard of care systemic therapy in the first line recurrent or metastatic setting for fit patients was the extreme regimen. So, extreme regimen they randomize cisplatin or carboplatin plus 5-fluorouracil with or without cetuximab. So platin with 5-fluorouracil and cetuximab. That is the first line for recurrent or metastatic setting for the fit patients for extreme regimen.